So this is for the marketing reps to talk about our pediatric cognitive behavioral program for insomnia. It's important for you to know, if you're a marketing rep for our company, that sleep is a huge part of what we do. It is also one area in which we are truly dominant in the market. Our market dominance has to be maintained, and we maintain that by offering programs, testing, as well as availability that no other entity is capable of providing at this time. So that's something that's really important for you to know. It's also important for you to know that our sleep referrals do not just feed our sleep clinic as well as our sleep lab, but some of these patients also require pulmonary evaluations and management as well as allergy evaluation and management. So they actually feed into the entirety of our program and help us to maintain our competitiveness. Now, our cognitive behavioral therapy program was designed by me for the Children's Lung, Asthma, and Sleep specialist, and it is a 10-week cognitive behavioral therapy program that is targeting childhood insomnia. The focus here is on changing behavior and modifying behavior as a way of improving childhood insomnia, with a strong emphasis on not using medication. Now, this is very important. First of all, there are very few medications. In fact, there are none that are actually approved for insomnia in children. But more importantly, it is very important for us to make an attempt to manage insomnia in children without medication, and this is how we go about doing it. The goal is to equip children as well as their families with lifelong sleep management tools. So this is what our cognitive behavioral therapy guidebook actually looks like. Every patient that comes to the clinic for our insomnia program will be getting this book. It is actually a 16-page book which was developed by me specifically for our practice, and it is supposed to work as a workbook and a follow-on guide for our patients while they are in our cognitive behavioral insomnia program. So every patient will get a copy of this book at their first visit, and it's going to be their guide throughout the process. The introductory page, which is the first inside page of it, actually talks about the program in general, laying out what each of the 9 visits, which are conducted over the 10 weeks, is going to be all about, and also showing them the 3 primary pathways that we're going to be using when we are doing the cognitive behavioral program with them. Thereafter, subsequent pages basically go through each week in more detail so that they can have a better understanding of what we're doing. What we're going to encourage parents to do, or children to do at this point, is to also write notes down either in the booklet or attach notes to the booklet as they're going through their weekly program, so that they can actually have additional information alongside it. The book is actually very comprehensive. In addition to having the summary of what's going to happen, as well as a more in-depth plan for them to know what's going to happen on each week. I've also put in addenda inside the book explaining what all the different processes, what stimulus control is about, what sleep restrictions are all about, what cognitive therapy is, and what relaxation techniques are all about. And these are put in detail, and in addition, we've added references in there. So it's a very, very, very detailed booklet. And finally, I've also added a 2-week sleep diary log in there, so that they can also have that. They can make copies of it multiple times and use it to actually do a better job of monitoring their sleep on a daily basis, so that when we see them in clinic and we're talking to the patients, we can have an idea of what their sleep week was like, rather than them trying to recall it from memory at that point in time. Now, it's very important for you to know that this booklet, which you will be getting a copy for yourself, is only for you to show the primary care physicians. You are not to give it to them. This is actually proprietary information. It is only for our use, as well as for us to provide the patients. We do not give this to the pediatricians. What you will have, on the other hand, to give to the pediatricians when you see them is going to be a flyer, which is this, which is actually a cognitive behavioral therapy program for insomnia in children. It is actually just a 2-page flyer, the first page of which is actually going to give a summary of what the 10-week program is all about. It's actually what is on page 2 of the actual booklet. And it also is going to talk about the different techniques that we use. Again, this is what is on page 2 of the booklet. That's what they're going to get. The back page of that flyer is going to have the kid sleep screening questionnaire, which is our own in-office developed sleep questionnaire, which we have presented at the sleep meeting. And we use to look at sleep disorders across different domains, and we'll talk about that later, as well as an Epworth Sleepiness Scale for children and adolescents, which is used for evaluation of hypersomnia as well as narcolepsy in children. So that's what the pediatricians will get for their own use. But the booklet, again, is solely for you to show them what our program is all about. We want to run our own program. We don't expect other people to run it. It's important that you show them the booklet so they see what we're doing, but you do not give the booklet to anyone. So this is sort of what the program looks like. And this is going to actually be on that worksheet that we do give you, that the pamphlet that we do give you, that you will be able to hand over to your pediatrician. That will have just 2 sides to it. This will be on one side of it. It will have the 10-week cognitive behavioral program for insomnia, and it will list out exactly what each week does. So you can go over that with the pediatrician and just show them, hey, this is what the different weeks look like in terms of our cognitive behavioral program. These visits can be done in person in the clinic. Preferably, we want the first visit to be done in person. The second week, the subsequent visits do not necessarily have to be done in person and can be done through telemedicine. But in between, we will probably bring the patient into clinic if we feel that it's necessary. We're going to have 3 main pathways through which we we address insomnia over those 10 weeks, and those are listed on the pathway 1, 2, as well as 3. There may be variations, there may be overlaps, but those are going to be the normal path. Those are going to be the pathways. What's nice about this is that for the parent and who is bringing their child into clinic, in the back of these brochures that or these booklets that we're also giving them, we've also included an appendix, and that appendix actually includes detailed explanations of each of these different um, modalities: stimulus control, sleep restriction techniques, relaxation techniques, cognitive therapy. There were actual appendices for each one of those. So there's an addendum for each of them, as well as references that are also included in case they actually want to seek more information. So this booklet is going to be a really good work tool for families to work with, but it's also going to be an important reference for them going forward after their child is cured. These are some of the screening tools that will be on the back side of the pamphlet that you will give the pediatrician. This is actually for them to use. The kids sleep screening questionnaire is actually one that we developed, we own, and we trademark it. It consists of 9 questions. The 9 questions look at different domains of sleep. So if you're looking at the kids sleep screening questionnaire, the first question is, does your child snore? That is actually related to the domain associated with sleep disordered breathing. The second is your child a restless sleeper, which is related to movement or movement disorders in sleep, as well as restlessness in sleep. Does your child have difficulty falling asleep? That is looking specifically at insomnia disorders or difficulty with sleep initiation or maintenance. Does your child sleep too much? Does your child fall asleep in school? Those 2 questions are looking specifically at excessive daytime sleepiness, both at night as well as maladapted or abnormal excessive sleepiness present in the daytime, which might be something that you would see in hypersomnia, narcolepsy, or someone who just had poor sleep at night and is now sleeping through the day. Also, you have questions about a child waking up a lot at night. That would be a question that is related to early awakening, disruption of sleep, or anything that might affect sleep, including conditions such as periodically movement in sleep, sleep fragmentation for any other reason. So these are all things that can impact sleep. Then we have a question related to waking up, screaming, crying, sleepwalking, and sleep. This is targeted specifically at the parasomnias, which are disorders of arousal from sleep. Thereafter, the next question, which is, does your child have behavioral concerns, learning problems, or trouble with concentrating or focusing, is specifically put there to look at the implications of sleep on behavior. So if you have a child who snores and also has behavioral concerns, learning problems, or trouble with concentrating or awakening, or concentrating or focusing, there is more likely there's a stronger likelihood that that snoring might actually be of significance. Same thing with restless sleep and behavioral outcomes, or being excessively sleepy and also saying yes to number 8. So in general, number 8 is looked at as a way of tying together sleep disorders with the implications of those sleep disorders on the neurobehavioral and neurocognitive functioning in children. The ninth question, which people don't focus on much, is just a question related to unusual parent behaviors when it comes to their children. So, does your child require medication to initiate or maintain sleep? If the answer to that question is yes, that in itself is a problem because children should not require medication to sleep. So, if a parent is circling yes to that and says, for example, that they do that fairly frequently, then that's a parent who really needs to have their child looked at because it is unusual for a child to require medication to sleep. So again, if the parent was to answer yes to two of these questions, two or more of these questions, there's a very, very strong likelihood that they have a sleep disorder that needs to be evaluated. They could still have an issue if there's only one question that they circled yes to, but circling yes to two would definitely suggest that there might be a problem. The second thing that we have here is the Epworth Sleepiness Scale for children and adolescents. This is looking specifically at hypersomnia as well as narcolepsy, and it grades 8 different behaviors and asks you to judge the likelihood of falling asleep during those activities. The activities are noted there, and the scale is that there's no likelihood of falling asleep, slight likelihood, moderate likelihood, and high likelihood. A score of higher than 10 would suggest that the person has a higher degree of sleepiness than usual and that it requires further evaluation. Now, it's important to understand the impact of pediatric insomnia in general. As a chronic disorder, it can affect behavior, learning, and overall health in children. It's also important to note that 30 to 50% of children may experience insomnia symptoms throughout their childhood at one time or the other. Medication is not often recommended for long-term use, and in fact, there are no medications that are actually standardly approved by the FDA for the treatment of insomnia in children. There are medications that we use, such as melatonin, Benadryl, clonidine, as well as natural agents, but none of these are actually approved specifically for use in insomnia in children. The cognitive behavioral therapy program that we have created offers a structured, clinically backed alternative, which doesn't just help treat insomnia at the moment, but also provides the child as well as the family with lifelong skills that they can use to reduce the likelihood of debilitating insomnia in the future. For a clearer understanding of what this actually means in terms of the cognitive behavioral program, the first visit, which is week 1, is all about initial evaluation of the patient. At this time, we're going to take a history from the patient, do a physical examination, and determine if they're going to require any form of testing before we move forward. That testing might include a sleep study if there's a suspicion of sleep disordered breathing. It may actually involve us just having the patient fill out a sleep diary. which is a log sum of their sleep and can be as long as 2 weeks. We're actually going to be providing them with sleep diaries to use, both electronically as well as in paper form. And then if they need any labs to be done, for example, labs for conditions such as restless leg syndrome or restless sleep disorder, then all of those labs will be ordered at the initial evaluation. There is no visit in week 2, and that's specifically because we're giving the patient time to complete all the paperwork that they need to do, including any testing that needs to be done, and then they will return for a follow-up in week 3, at which time we will review their sleep diary, we will review their labs, we'll review any questions that they have. At this point, the patient will already have the booklet, which would have been given to them from week 1. So hopefully they would have started looking at it and they may have some questions. And once we've done that, at week 3, we're going to determine what cognitive behavioral plan they're likely to go on. As noted, we do have 3 different pathways that we've specifically developed to at least start the patients on initially, and they will go on one of those pathways. It could be stimulus control and sleep restriction technique pathway. It could be pathway 2, which focuses on stimulus control and relaxation techniques, or it could be pathway 3, which focuses on relaxation therapy as well as cognitive therapy. So we're going to decide which one to start with, begin down that pathway, and then gradually through weeks 4 through 10, we will tweak the pathway that the patient is on, either by adding further instructions about how to incrementally increase the gains that they're making from one week to the other, or if necessary, switching pathways, adding new techniques, and teaching them how to do those pathways. So even though we have 3 tailored pathways, these pathways can be intermingled to try and get the child to a point where they are successful in managing their insomnia. Again, we have a focused approach on managing insomnia over 9 visits and 10 weeks, because we understand that it's not just enough to set this program in motion, but we also have to set a standard for actually achieving the goals that we need to. Now, should the goals not be achieved by week 10, there's obviously room to continue, but we have a firm, organized scientific approach to trying to make sure that the success is achieved within the 10-week window. The tools that we're giving to the pediatricians, in addition to what I've described to you for the patient, include the Kids Sleep Screening Questionnaire, which is the 9 questions on the referral guide, which we're giving to you to give to the pediatricians. Now remember, you're going to get 2 specific worksheets to give to the pediatrician. One is going to be a worksheet that is specifically for the pediatrician, that has an introduction of our insomnia CBT program on the front page of it, and on the back page of it is going to be a kids sleep screening questionnaire, as well as an Epworth sleepiness scale for children and adolescents. That is really for the pediatrician, but it's important that in addition to giving the pediatrician a copy of their own, we're also asking you to put a few copies in our binder, which every pediatric office should have. The reason why we want that is because if a pediatrician does see a patient that they want to refer to the program for their CBT management, they may want to give that patient that cognitive behavioral plan to say to them, hey, here's the plan that this office is likely to use on you. Oh, and by the way, when you go to them, they're going to institute this plan. They're going to give you more tools, including a booklet of your own, which you're going to use to manage you. So that's why you do that. The other thing that you're going to get to give to the pediatrician is specifically for them to either use for themselves or to give to the patients to use. And it is a 2-page questionnaire or brochure, really. There's a 2-page questionnaire. One side of it is a 2-week sleep diary, and the second side of it is a kids sleep screening questionnaire, as well as an Epworth sleepiness scale for children and adolescents. The reason when we're giving you that is because if a pediatrician sees a patient and they're referring them to us, in addition to them giving them the the CBT sheet that explains the CBT plan that we're going to use on one side and has those questions on the other. You're also giving them a sleep diary that they can immediately begin to fill out, so that by the time they come to our office for that first visit, they've already filled out that sleep diary, which means that we already have 2 weeks, most hopefully, or thereabout, of their sleep patterns and characteristics before they actually ever show up to clinic. In addition, they have an opportunity to fill out the kids sleep screening questionnaire, as well as the EPO sleepiness scale for children and adolescents. When they do come to the clinic, they're going to have to fill them out again. And the reason why we do that is to ensure that the EPO sleepiness scale and the KSSQ, that we get answers that are sort of representative of what is truly happening to the patient. So if the parents fill out the ESS CHAD as well as the KSSQ, and their answers on both of the different visits, on both of what they did at home and what they do in the clinic match, then we can at least say with some degree of confidence that we actually treated, that we've actually got that process nailed down, and that the data that they're giving us is actually truly useful. So if you're explaining to the pediatrician, it's very important for you to explain to them that the first flyer that you're giving them has a description of our cognitive behavioral therapy plan. So it will include what the 10-week plan is going to be about, and it will also give them an introduction to the different pathways that we use. And on the back of it, you will have the KSSQ, which is our Kids Sleep Screening Questionnaire, as well as the ESS CHAD, which is the EPO Sleepiness Scale for children and adolescents. That is for the pediatrician to have, to understand what our program is about. When you hand them that, part of what you will do is show them the booklet. Remember, the booklet is not for the pediatrician. That is for you to show them what we will be giving to the patient. It is a booklet that is the only reason why you're getting it is so that you have it for your own reference and to be able to show primary care physicians what we actually do. But you are not to give that to the primary care physician. Explain to them, however, each of their patients will get their own copy, which they will use both for their in-office as well as telemedicine clinics as a reference guide. The second flyer that they will get is specifically for them to either use with their patients or to give to the patients to use when they're coming to see us. And that's the one that has a sleep diary on one side, as well as an EPO sleepiness scale and a KSSQ on the back side. So those are the two that you will get. And it's super important that you make sure that both of those are inside these binders that you are giving to the pediatrician. So when a pediatrician gets this binder, the binder should include a referral form, which may be a custom referral form for that practice. It should also include some of our actual practice brochures. It should include your business card inside there as well. In addition, you should have at least 6 to 10 copies of each of the two flyers that we're giving you to give to the pediatrician to either use for themselves or use and hand to the patients when they're coming to see us. So it's really important that this binder always have things in it, and that whenever you go to a pediatrician's office, you refer and reference this binder, because that's where you're going to put all of the information that you have. Now, it is super important that you do that, so that we can continue to maintain our dominance as far as referrals for sleep disorders are also concerned. And also because, truthfully speaking, we can manage the patients much better than anyone else can. Again, why should pediatricians refer their children to this program? Well, first things first, it's a non-pharmacological, child-friendly approach. What does that mean? We are going to try and make sure that children with insomnia can overcome this condition without sentencing them to a lifelong history of being pill pushers and pill junkies. We do not want children with insomnia to end up being kids who are on medications, which they could potentially be on for life. Because when you start treating someone for insomnia with medications, it is very hard to get them off those medications once they get used to being on them. So the key here is to actually treat insomnia by modifying behavior. So we're going to use cognitive behavioral therapy strategies to reduce the insomnia symptoms on a long-term basis. By treating the insomnia, we're also going to help them address some of the comorbid conditions that might be associated, such as ADHD, anxiety, as well as learning challenges. Now, remember, we do not treat ADHD, anxiety, or learning challenges. However, if we can improve sleep disorders in our patients, then conditions such as ADHD, anxiety, as well as learning challenges may become much more manageable for the primary care physician. Also, while we're evaluating our patients for insomnia, we're going to be looking for some conditions that may be associated with things like ADHD, such as restless leg syndrome, restless sleep disorder, as well as periodic limb movement in sleep. In addition, we're also going to be looking at conditions that can disrupt sleep in general, including obstructive sleep apnea, as well as hypersomnia disorders, including narcolepsy and idiopathic hypersomnia. One of the things that makes us very unique in our approach is the fact that we have multiple convenient physical locations spread out throughout the state of Florida. And we have 15 physical locations where we can actually see patients in person, ranging from Tampa to Tallahassee, and from uh, West Palm Beach to Daytona. And we also have the office in Jacksonville where we can do sleep studies. And then we have everything that lies in between those areas where we can also manage patients. So our approach allows patients to actually be able to come to us and come to see us at locations that are not too far away from where they are currently based. But also, our use of technology allows us to use telemedicine to also facilitate their appointments. So there are times when we will use telemedicine, which will help to shorten the distance between us and the patients and allow us to conveniently provide that service while also reducing um, losing patient visits due to no-shows and stuff like that, since we can accommodate them in a telemedicine platform. Again, this is very important for you to present to the pediatricians. They need to understand that this approach is based on maintaining a non-pharmacological child-friendly approach, first of all. Two, to teach children and parents long-term behavioral strategies for treating insomnia symptoms without making them subject to the use of medication. Three, to help address and reduce comorbid issues such as ADHD, anxiety, or learning challenges that can be related to poor quality sleep. And fourth, the fact that we can provide that service to them in multiple locations throughout the state of Florida, but also through telemedicine if needed. So how does this process work? Well, pediatricians can either use the referral forms that we're providing to them in the binders, or they can use their own referral forms, or, or electronic referral forms, or phone calls, or ask parents to call us. We actually prefer that pediatricians actually initiate the referrals themselves, first of all. From a documentation, it is better when they send us the referrals directly themselves, and for them to understand that we will send them referral acknowledgements as soon as the patients have started in the program. We tend to provide what we consider collaborative care. We work with the pediatricians. They should expect that after every visit, they will get an update from us indicating what we've done for the patient and what we're going to be doing next. We will be providing pediatricians with material, brochures, questionnaires, and informational materials that they can give to parents. Ultimately, it's important for everyone to understand that we need to work together to improve kids' sleep health, and we're very determined to do that. And our goal is to always see every new patient if in less than 2 weeks, and where likely and where possible in under 1 week. That is our goal, to see the patients that quickly. If they need sleep studies, again, the goal is to have that done in less than 2 weeks and for results to be back to parents normally, to pediatricians, normally within 48 hours. We tend to turn our notes over within 24 hours, so pediatricians should expect to get their notes back from us normally no later than the day after the patient was seen.